Okay, good morning everybody and welcome to this DLF Professionals webinar. This webinar is entitled Assessing for Aids and Adaptations for Independent Living in a Pandemic. Just a few kind of housekeeping things before we start. You will be able to ask any questions as we go on. However, if you could put those into the chat box function within Zoom, that would be great. If you are watching via Teams, then there is a chat box function in Teams as well. You can put it in there and I will collate them all as we go along, and I will put the questions to the speakers at the during the question and answer session, which it will be at 11:45. We won't be asking speakers questions as we go along, simply due to the time constraints. All right, well, without further ado, I am going to pass over to Melanie Poyser, and she's going to start with an overview, as you can see. Over to you, Melanie.
Thank you very much, James. Good morning, everybody. My name is Melanie Poyser. I'm the Partnerships Manager for London and the South East of England, and I'm the Special Projects Lead for DLF. DLF is really at the forefront of trying to promote independent living for people with vulnerabilities, those with a disability or older people. And during the past 18 months, there's been numerous different kind of challenges that we've had to adapt to, as everybody has. So just a quick review of the past 18 months. At best, it's been challenging, and at worst, it's been horrendous for people on a personal and professional basis as well. Before we continue, I think it's really important just to acknowledge those who have worked at the front line of the pandemic and or at the back end, strategically planning for service delivery. It has been an amazing achievement in terms of what you've contributed, and we are very much grateful for that. So just looking over the past 18 months, what's happening? So really, some of the things have remained exactly the same. We haven't stopped aging. We're still an aging population. But one of the things that has kind of progressed along is that declining health for people with existing health conditions. Those have been exacerbated, as well as new conditions emerging, some of them from long COVID, some of them just being because a lack of attention. Amongst the vulnerable, what we've seen is that the multimorbidities are increasing for them. And that has been something that's been at the forefront for everybody, even pre-COVID, how we can reach the most vulnerable in our society. And during the past 18 months, that has increased dramatically. And part of that is because having accessibility to services, those traditional pathways of being able to see your GP, going to clinics, appointments, having face-to-face assessments, they've all changed, and some of them have become inaccessible. And that has meant that we've had to adapt our service provision and how we can deliver our services because of social distancing. But one of the things that we have seen, that as horrendous as COVID has been, there are opportunities to be had in terms of our service delivery. And one of the things that organisations are constantly telling us, it's forced us how to review how we deliver services. And for many organisations, it's meant an acceleration in their transformation plans that they had for the next 5 to 10 years, they've had to bring forward to now because of the way how COVID has progressed and just the needs of their populations. It's highlighted the strengths and weaknesses within organisations and identified gaps in their service provision. And what that has meant is that there's been a real genuine focus on client-centred care. And for organisations and for service users, we can see that one size doesn't fit all. It's really about how we can make services more appropriate. And part of that is really escalating partnership working within the multidisciplinary teams in health, housing, social care and care provision. One of the key areas that we're really seeing is that as we're starting to emerge out of the worst of the pandemic, is that we're going to have to now create a new normal. And one thing we know is that it will reshape our world. It has changed everything. But one of the key things that we really need to kind of look at here is the fact that we have started that work. There is a blueprint. The work that we've implemented during COVID, we can continue that into the future and build on that. Within DLF, we've also been affected and we've had to adapt our service as well. But one of the things that I'm really proud of within DLF is that we remained open throughout. So throughout all the lockdowns, we've continued to deliver training and we've continued to provide information and advice to the general public, which has been really important because other avenues of information and advice and help were not accessible. And one of the key areas that we really are proud of is our trusted assessor training portfolio, of which we've got 5 levels that now been developed and exist within there. And although it's not a new concept, it has found a new relevance in this space because of the need for assessment and to upskill a lot of our professionals in how to do assessments in this current climate. So what have we done? One of the things that we have done is we've moved and changed how we deliver our training. So our most popular course, our assessing for minor adaptations, our level 3, we actually moved that online, which is something that we had planned to do. But as I said, many organisations had to fast forward some of those transformation plans. And it's been a huge success. People have been able to tap into that at their leisure and be able to complete the training online. As things started to open up, we have our level 4, which focuses on major adaptations that we normally do under the Disabled Facility Grant, the DFG. And what we've done is we've created a blended learning format, which means that you get the luxury of both worlds. You complete part of it on the e-learning platform, as well as attending a practical assessment at one of our training centres. One of the other things that we do is we're trying to promote more confidence amongst our professionals, and we've developed the level 5, which is looking at how professionals can look more in depth at more major adaptations. So things around the kitchen, the bathroom, multiple level access to the home, and the legislation that is contextualised within. One of the areas that I'm constantly doing is looking at how we can bespoke courses for our local authorities and for organisations. So really it's about looking at the needs of the organisation, how best our training can fit within what you want to deliver. So sometimes local authorities want to have a more standardised approach, and that's important to ensure that what we produce enables them to do that. And of course, we're constantly looking at how we can develop our courses, so looking at how we can look at the issue of remote working and remote assessment and how people can better provide a service for service users. The successes for us has been that over 800 new learners have registered onto our Trusted Assessor training courses, and of that 778 have been taken up in terms of the level 3, as I mentioned earlier. And what that really shows us is that our training is very universal. We have numerous different types of organisations and teams within those organisations, within health, housing, social care, and within the third sector, that actually have completed our Trusted Assessor training in the past 12 months. It's about 548 learners that have gone through. One of the other tools that we've developed is ProAssist, and that's the latest in our portfolio of services and products. And that's an essential tool for anybody who prescribes any types of equipment. The key features here is that it's evidence-based decision-making. So one of the things we really wanted to highlight was to ensure that when professionals are making any kind of prescription, that they are backing that up with evidence. It allows them to explore a whole world of assistive technology, things that they may not have come across against, but are pertinent to those conditions to enable a better quality of life. It allows the professional to create reports, either for business cases or if they need to print that off to show a client. So the client can be caught up in that whole kind of process of what kind of equipment the professional wants to prescribe for them. And one of the key parts of ProAssist is that we're trying to develop a community, a prescribing community, and there's availability there for you as the professional to access it and to put your information and your evidence of what you found about certain types of equipment onto ProAssist as well. One of the key areas as a charity is that we really want to empower our service users, and we're doing that through our Living Made Easy programme, which is our public-facing programme, and also through ARC SARA, which is our online assessment tool, which is enabling older people and those with disabilities and their carers to make informed decisions about what their care can look like. So what have we done? What we've done here is that we've looked at how we can redesign ARC SARA so that it enhances the customer's journey into assessment. We're working constantly with our suppliers and retailers, making sure that we have new suppliers and retailers that are available to both the public and professionals. We're working more consultatively with organisations so they can develop their own local licensed versions. And one of the key things we've seen in this current climate, that self-assessment and private purchase has become much more common, because people just haven't been able to get hold of some of the things that they need to get hold of in the traditional ways. But what it's doing is educating the service user about what is existing out there. And some of those things would not have been available by a local authority anyway. So it's really expounding their world so they can see what else they can have in terms of equipment solutions. So just in conclusion, really, what has the past 18 months shown us is that we need to start thinking differently, how we can adapt our services so that we are providing the needs for the diverse population, and what do we need to put in place so that we can enable people to have a quality service and an appropriate service as well. And that's one of the things at DLF that we really want to work with you as local authorities, as organisations, so that you can find the right solutions in terms of the services and tools we provide that will in turn help your service users and your staff to do what they need to do. And also as you as a professional, you can feel more competent and confident in when you are assessing. Thank you.
Thank you very much, Melanie. I'm going to hand over now to Nick Bowyer, Boyer, sorry, Nick. I don't know which, from Staffordshire County Council. So I'm going to share your slides for you, Nick, and then if you'd like to unmute yourself and start your video, and then carry on.
Thanks, James. You were right. First time it is Bowyer, as in the making of those things that fire arrows. We've got our own tower in the Tower of London, actually. One of the but I don't lay claim to live in there. But thank you for inviting me today. As James has said, my name's Nick Bowyer. I'm the practice development lead for adult social care from Staffordshire County Council. So what I was going to do this morning was just give you a brief oversight of Staffordshire, just quickly. What the legislation is that social workers work to, which some of you may know, but and then look at how the pandemic affected those pieces of legislation, some of the ethical issues that were thrown up, how our services were already changing before the pandemic, but how the pandemic acted as a bit of a catalyst in moving us on quicker than a lot of people were comfortable with, actually. And then a bit of a overview of what digital resources we've got locally, and another couple of resources. And my colleague Lee Owen is on the call. Oh, he's told me he's joining this morning, so Lee may jump in at points if he's got anything to add to what I'm explaining. So Staffordshire is a very large county. We have got the highest village in England. Oh, there, Lee's there. Thanks, Lee. We've got the highest village of it in England within our county boundaries, and that's a place called Flash up in the Staffordshire Moorlands. And we stretch as far south as just north of Kidderminster, because we've got the Seasden Peninsula that runs down the side of Birmingham. Very urban county, but we have got a number. Very rural county, but we have got a number of centres of urban population, with deprived communities as well. There's some ex-mining communities in Staffordshire. So the legislation that governs social work, we've got these are the three key areas of legislation. There's others, but these are the three key ones. We've got the Care Act 2014, the Mental Capacity Act of 2005, and the Mental Health Act of 1983. And threading through all of those, we've got the safeguarding principles that we work to and affect those areas of legislation. Thanks, James. James very kindly doing the slide, so we had a bit of a technical technical glitches just before everybody came on. So anyway, the impact of the pandemic on those areas of legislation. So with the Care Act, there was COVID legislation that came out that enabled local authorities to move into what was called easements. Staffordshire was there wasn't many local authorities that did move into easements, but Staffordshire did. Now, fundamentally, it didn't change things that much for practitioners and for people we support. Nobody was left at risk. People were still engaged with. What we did not concentrate on as much was looking at areas of need around people accessing things like day centres or addressing social isolation needs by introducing people into social situations for obvious reasons because of the restrictions that the pandemic brought. So although we did move into easements, it didn't affect our practice that much, and it didn't impact on the population of Staffordshire that much in relation to their social care needs. If anybody was at risk, we still met their needs, and if anybody did need periods of respite away from their home because of safety issues, that was facilitated by us using our in-house day service provision that we've still got a number of those, and they were used, and we took all the precautions there is around the COVID and cross infections, etc. One of the things we did do was actually mobilize our day service in our internal day service provision staffing cohort to assist in keeping engaged with people. So they were phoning people on a regular basis. The people we support, they were checking on people, what the situation was like. They were coordinating food drops to people, etc., etc. So we, with that cohort of the workforce that couldn't go in and do their normal job, we utilised them, and it was very effective, and they did some really good work. In relation to the Mental Capacity Act, and I know a lot of other local authorities did adopt this approach, and have adopted this approach, and it's still happening. Best interest assessments under the Mental Capacity Act were moved virtually. They were moved online, so they were done either via telephone calls or via utilising video apps for people who were in residential nursing provision, and it proved very effective, and it is a practice that is still continuing now. So I authorise best interest assessments, best interest assessors assessments, and you see in there the detail. They record how they engage with somebody, and what digital resources or other resources they used, and what triangulation they did by talking to other people, etc., to make sure that they were able to conclude those assessments. The Mental Health Act, early on in the pandemic, the Mental Health Act and engaging with people under the Mental Health Act, some of that was happening virtually. Now that was legally challenged, so that again, it was legally challenged very early on from being inclusive. Our approved mental health practitioners had to go out and undertake in-person contacts with people to undertake the work under the Mental Health Act. I've put links there to the pieces of legislation because obviously there's because of time constraints this morning, there's a lot of information there, but the slide packs will come out after, so if you're interested in those areas, you can just click on those links and it should take you to those. Thanks, James. Now what it has done in our shift in practice, because what social workers were doing, the predominant amount of work that we engage with people under the Care Act, that engagement for social workers shifted to virtual contact. So it was either via telephone calls or video enabled apps that people were being contacted and engaged with to undertake those assessments. Now that has thrown up significant ethical challenges for social work and social workers as a profession, and that isn't just in the United Kingdom, that's nationally. Internationally. This is taken from an international social work site, that quote. I'm obviously not going to read it because you can read, but again, if you're interested in that, that link will take you there. Now, what we did as a local authority to support our workforce, we utilised Microsoft Teams and set up forums where practitioners could engage with us. That has proved really, really successful. Our engagement with our wider workforce is much better now than it was prior to the pandemic because of our use of MS Teams. We hold forums that get upwards of 150 plus practitioners engaging with us, and they do engage. They're very much interactive sessions. So we set some sessions up about the ethical challenges that the new practice was bringing in, and sessions around reassuring practitioners that what they were doing was still ethical, and how best to, how to adapt to this new way of working. Thanks, James. So, as I said earlier in the introduction, we had already started moving the way we were practicing. We'd established prior to the pandemic, a couple of years prior to the pandemic, a team called a First Contact Team. Now, that First Contact Team is made up of social workers and social care assessors who, apologies, that's the doorbell, it's probably Amazon, sorry, who engage with people in Care Act compliant assessments via the telephone or via video enabled apps. So that was already happening. That First Contact Team do not engage with people in in-person settings at all. If that's required because of risk or any other issues, the person is referred onto a community-based social work team who will visit the person and engage with them. So we were moving to a more virtual way of practice before the pandemic. What the pandemic did was accelerate that. Now, we recognise if we take a proportionate approach to engaging with people, which the Care Act talks about proportionality, not everybody needs an in-person contact or a visit to their house, knock on the door. That can be very intrusive for people, and that was one of the things we talked about in our engagement with practitioners. People are phoning us up who in circumstances that are very challenging. To have a social practitioner knock on your door and come into your house is very intrusive and is not required for everybody who gets in touch with us inquiring about support. Thank you, James. So just a quick run through what we've got locally is for digital resources, and this is for members of the public and for practitioners. We've got Staffordshire Connects that is accessible via our website, the link's there. We've got Happy at Home, which is a virtual house that people can go and visit and see, look at pieces of equipment and other things that might help them to remain as independent as possible, that they can access. But what we've also recognised, and it is an issue, is that a lot of the people we support are digitally excluded. They cannot access, they don't have the hardware or software or equipment in their homes to be able to access a lot of resources. So we recognise that, and we want to address digital exclusion because it is a significant issue the more we move to online and engaging with people virtually. So what we've got is we've set up community help points, and as I said earlier on, we're a big county, big spread of population, very rural, but with those areas of population that we've got libraries in those areas, and we've also got library vehicles that do travel around the county, and we've set up community help points so people can physically go to those help points, and those help points have got the hardware to enable people to access digital resources. And that was to address the digital exclusion. Thank you, James.
Lovely. Thank you, Nick. Much appreciated. Very interesting. I know there's a few questions coming into the chat box as well for you, so we will send them to you during the Q&A session. So thank you very much to Nick. I'm now going to share the screen for Damien, and this will be for Damien Nolan. And Damien, I will hand over to you.
Sorry, I've just unmuted. Thank you, James. Good morning, all. My name is Damien Nolan. I run the franchise of Home Instead, which is in northwest Surrey. So the best way to describe it geographically is sandwiched between Kingston. Sorry, first slide or next slide, please. So sorry, guys, I wasn't quite. I wasn't quite sure of the audience, so forgive me. So I've just put in a quick snapshot. As a business, we're outstanding from the Care Quality Commission, of which only 5% of all domiciliary care providers have across Britain. So we're quite proud of that. Currently, we look after 130 clients, using about 100 staff, although that fluctuates. And as you can imagine, in the current climate, is proving quite a tough ask in delivering at this moment in time. The majority of those 130 clients are self-funding, i.e. private clients, so would not be sitting inside the normal adult social care teams. However, we do report to adult social care, and we do work with local Elmbridge Council and others on occasion with certain packages, and we deliver to the NHS. So at the moment, there's huge demand, as you can imagine. So at the moment, I think there's something in the region of 30 people waiting to come on, and 1,200 hours of need. And the reason I'm mentioning that is because we'll come back to why we've set up the way we have. So it's over 1,200 hours, and I can't give you exact figures, but people's needs are more acute because they're being excluded from the NHS or not reaching the resources or accessing what they need, and therefore people are coming to us and an incident has happened or occurred. As a business, we want to do everything to improve client and family experience, and hence engaging with the trusted programme. And also, as an integral part of that, is about us having exercise plans for every client that comes in, including well-being. So we're relaunching our dementia-friendly cinemas, for example, on the 1st of November. So it's all about the overall well-being of clients, not just physical or environmental, etc. And we're also engaging on technology, which again I'll come back to in a little bit because that has stumbled due to COVID. And the one thing I've been kept saying to staff internally, if we think we're struggling now, then I predict a very long winter. Trying to prevent people from having anything happen to them is probably the best course of action, really. But I think we're probably all signed up to that anyway. Next slide, please. We started with Melanie and the Disabled Living Foundation just right at the start of the pandemic. If my memory is right, it was February. And then we progressed through the part of the year, and then the pandemic hit. And we were working on a bespoke method of how to work with people. So going back, those 30 people on the waiting list, one of our mantras and missions internally is that we go and see everybody within 24, 48 hours when they call us as a home care domiciliary provider. I always say to staff that it's like if it's your own mum ringing in, get out there and see them. Obviously, we changed that a little bit during COVID and people having fear, etc. So we did telephone and remote sort of working off doorsteps and various things. But of those 30 people, whether we take them on as clients or not, I think it's incumbent upon us. It's our duty of care. You know, just the decent thing to do in humanity is to be able to identify any problems. And if we're not going to look after them, signpost them to the relevant places. And then ultimately, what we wanted to do with every client that we do take on is to help them improve their independence, to remain, you know, at home as they so wish, and to reduce the actual cost and size of the package of care. Quite often we got bound up in high cost packages because it's double ups, etc., and the law dictates what we can or can't do. But I just see it as people who've worked past the, you know, since the war, have worked hard, did everything, collected their pension, etc. And now it's sort of flittering away, but that's a side political issue. But anyway, what we want to do is make sure that we look after people in an affordable way as possible. So to date, and our information isn't exact, so I'll come back to that in a moment. So this is just to give you a flavour, and we're hoping to have more accurate information as we go along. Initial assessments, which basically is our consultation. So if you go out to see, if a family rings in, or we've had an email from New Zealand, can you look after me mum? The first thing we'll do is go out and chat to the person, explain how we operate. Now, at the same time, we're developing the staff to go out to be the first line of initial assessment of a trusted programme. So that means that the person who's going out to do the consultation can do a quick survey and make sure that that person's okay within the boundaries, as was mentioned earlier. Some people don't want you to be, nosing around the house, or they may have, just feel a bit fearful of somebody coming in and dictating, or tell them they can't live at home, etc. So you have to manage it very carefully. But when the person's there, they will assess the situation. So I just literally put in the slide, finalised this morning, I asked Ellie, who looks after that. And she said that the two serious things that came to mind with her was, one, she went out to somebody last week and she immediately told the family to ring 111 because it was a 94-year-old gentleman, and he and his family didn't realise how poorly he was, and she said, ring 111 now. So that's the first. And I've with Melanie in the past, and Claire, we're talking about how we can, I used to call these people our eyes and ears in the business, because they're on the ground. We've got nearly 100 of them, so they're out all the time. They can see if somebody's failing or if they need some support. So we were going to call them trusted eyes and ears, but we ended up with trusted enabler, which comes on to the second point. Sorry, the second person we recommended internally, and somebody went out and did a further assessment after the initial assessment. And that's the way we want to approach it, is not to get too excited or think that somebody's becoming Dr. Zhivago or whatever it may be. But if they see something they're concerned, report it internally, and then somebody else can go out and happen to visit and double check. So in the first level as an enabler, we've completed 91 to date. And just trying to get a flavour of everybody that's here and how we've done it. I mean, we find that we're very slow, and we think that COVID has really knocked how far and how fast we wanted to go with this. However, given the conditions that the staff are working in, sickness, fuel crisis, floods, pings, etc., we are so stretched. It's been hard to, I suppose, keep to a timetable. Very tough to try and keep to a measured way that we hope to approach it initially. And then the second level is trusted supervisor. So I'll come on to that in a moment. Next slide, please. And we've completed 91 of those. So the second level, sorry, which I haven't put on that slide, is the trusted supervisor. So these are people who are further assessed at level 3 that Melanie mentioned at the start of the webinar, is to enable more experienced staff to go out and do further assessments. So now, on our internal environment, we've called it environmental assessment form, and we've got recognition from the Disabled Foundation to be what's called, we've got the trusted assessor thingy that you might see on the screen behind me, but we've also got what we call a trusted business. So we're going to check in all the time with the Disabled Living Foundation and make sure that our standards are right, that our approach is right, and if we can gather any good practice or improvements from the Disabled Living Foundation, that we'll do that. And equally, anything that we achieve or recognise, that we can feed that internally as well. So on our form, the first thing that we do after taking some of the initial details of that person that we're going to visit, so it could be a prospective client or a client, is who will we report to? And one of the things, and this is a question to throw out there to the adult social care sector, and indeed everybody sees everybody as their territory. These are our clients or your service user, whereas actually they're just people who are living at home and want to remain at home. And I think it's incumbent on all of us really to share information with each other, whether we take that person on or not. And then when we do take them on, they can still be your service user and our client, but we treat them as an individual and make sure that the package of care and all the equipment and tools and aids within that suit what they need. So within our form, the first thing we do is who we're going to report to. So we've got the client. I think these come up at the end. So actually I might just skip on that, and I'll sorry, leave it at the end. I'm maybe going to cover myself. So we want to, going back to this slide with the integrated, we want to work with the public sector and the NHS. We don't want to exclude ourselves from anybody. So we want to work continuously with the Disabled Living Foundation, and I have to say, just to blow their trumpet a little bit, they've been fantastic in the way that they've been working with us to try and establish everything, especially due to circumstances. We're also working on technology and software to try and record all the information. So we're doing a lot on conditions. So whereas you guys might do it by, I don't know, ward or each borough or people with certain need, we want to try and track things by condition so that we know what are the appropriate tools and aids to give to people with dementia, people with strokes, people with sight, etc., and try and funnel it in ways through into Ask Sarah in a way that people can actually go and get the immediate little report that might be bespoke to them. We're integrating it with our care plans and with the families. So we're trying to make sure that we reduce the cost of package of care by saying, look, if your mum or your dad or your granny takes this, then it should reduce the package of care we estimate by X amount of months or X amount of years, etc., because they'll, you know, feel confident to remain independent. And a lot of it is to do with the confidence of the individual. Reduce the cost of and improve the experience, really. So alongside of this, we've got a lot of well-being exercises and physical exercise and stuff that we do with people, and I'll come on to that, and hopefully in the next slide, if I've remembered my order. The last thing is about standardization, which is also an appeal to everybody. So internally, we want to make sure that every member of staff, whether they're a trusted enabler or a trusted supervisor, are assessing the right people in the right way. So you can go to somebody and they're feeling low because they've got a cold, and that may magnify through a symptom, may magnify actually what they need. So it's really establishing with the staff internally to sit around on regular occasion and say, why did you come up with this? Why did you make that decision on that? So we integrate frailty, syndromes, conditions, symptoms, and environmental hazards, etc., as well as recommending tools and aids, etc. So it's a bit more of a comprehensive package, if you like. Next slide, please. So going back to stakeholders that were mentioned in the earlier slide, is we will automatically inform the family and client so they can have a copy of the report. Because quite often, if we said to Mrs. Mop, you need this, she'll probably think, no, I don't. Whereas if we let the family know or some loved ones, then we can say, look, if you can integrate this and you can ask the person to want to remain independent and not end up in a home or whatever it may be, then these are the kind of tools and equipment that you need, you could get your mum or your dad or whoever to buy into. But we can also forward on to the GP. If there's anything relevant to them, we can forward it on to individuals within the NHS. So it could be community nurse, a hospital department, etc. Adult social care where appropriate. It could be to a specific OT or physio that is related to that person, or recommended site. So it could be, I don't know, to the Alzheimer's Society or Disabled Living Foundation or whatever. You can recommend individual places for people to go based on what their conditions are and what their needs are. I think that's it, except because I've maybe not got the flavour that everybody else has had, is that we want to take this much further. We want to work with partners so that nobody's left out of the loop, and depending on affordability and demand and supply, etc., that everybody can feel part of a bigger network, and we can translate the information really quickly by digital technology, etc., to if we can't deal with it, somebody else can, and just make sure that that person's experience is put up and prevent them falling over, prevent them ending up in hospital, and preventing queues that might come during the winter. Thank you.
Nick, somebody says here, would be interested to hear from Nick whether the community help points will now be a longer term programme. Did Staffordshire have to develop tools to decide when to visit, and will this continue to be used?
Okay, first point about the community help points. Interestingly, the community help points, they're part of our supportive communities programme, which is led by Public Health. That was started, those community help points were started, the development of pre-COVID, and we were planning to launch them in March 2019, and then something else happened. So it was almost, those community help points were put into abeyance, but we're back to a point now where we're promoting them again. So very definitely it was something that was planned pre-pandemic, and obviously we're now continuing post-pandemic. In relation to assessing or indicating whether somebody needed an in-person visit, and the use of a risk assessment tool, I guess, is what you're doing. They were used. We didn't have necessary templated ones, but individual teams and individual practitioners were using resources like that to indicate where somebody needed some in-person contact. And we use the term in-person on purpose because we're face-to-face. So we don't use the term face-to-face because it's not prescriptive of enough of how somebody should be engaged with. So that's why we talk about in-person.
Fantastic, Hugh. Thank you, Nick. I'm going to go through these. I'm not going to go through them in any particular order. I'm just going to go through in how they come in. So the next question is for Damien. Can you tell me a little bit more about the Happy at Home, please?
That's Staffordshire County Council.
Sorry, that's me. Nick, it's
No
again for
problem.
you. I do apologise. Thank you, Damien.
I'm happy to try and answer it.
That's fine, but if Lee is still there, this is Lee's project. So rather than stealing Lee's thunder, if he wants to come on and just explain a bit more about Happy at Home,
You should be able to unmute and put your camera on, Lee, if you would like. I'm not sure whether he's still there, Nick. Actually,
he says.
Oh, okay.
There we
go.
There we go.
Hold on. Yeah. So the Happy at Home generally is an interactive house. Actually, I'll go back a bit. The Happy at Home is actually a campaign. It's a big project that we've been doing in public health and Staffordshire County Council. And generally what we're identifying is that not a lot of people out there, both public and professional, know about items of assistive daily living technology. They don't know that much about it. This actually shows good examples of what people can perhaps purchase themselves or what to look for. And we do that through the interactive house, which is on the website. But also on there, we've got, it's all to do with the Supportive Communities programme that Nick mentioned earlier. It's actually one part of it, the Happy at Home campaign. So generally, we're looking at keeping people and, helping them to remain independent in the homes through the use of technology. And that's what the Happy at Home project is. And if you go on the website, you'll see all different things like fact sheets on there. You'll also see videos. There's actually film footage of me showing some examples of a project that I've been working on a number of years called the Box of Tricks, which is generally items of technology that you can buy from your local shops. But there's all sorts of advice on there, and the idea, like I say, is to focus on giving information to both public and professional. It's also a tool. That's what generally it is. It's a useful tool, finding information.
Thank you, Lee.
Okay,
right, Damien,
cheers.
I'm actually going to come to you this time.
No problem.
So, question for yourself: when a face-to-face visit is arranged, is there a minimum visit duration that would be considered of good quality?
Well, it's a glamorous word, guys, but it's when things were normal pre-pandemic. It's called a consultation, and it's a question. It enables people to ask questions of our service and how we use it with others. Plus, we explain to them how it can be used, because it's self-funded. People purchase in a completely different way than maybe a lot of you guys have it prescribed to you by ancient systems. So we normally say between half an hour and an hour, but it really depends on that person, how they engage. And we'd always encourage a family member to come so they don't feel coerced. But where appropriate, the person then is, we ask people to observe everything they can in the house. So historically, when I was doing it, for example, if Mrs. Mop asked me for a cup of tea, I used to say no thanks because I didn't want to trouble her. Now I realise you can measure her gait and movement under the frailty scale to see if she gets up, and then I might go to the kitchen with her to see whether she can lift the kettle, etc. So to try and answer the question, whoever that's from, probably half an hour to an hour, but we always leave it that there should be a second assessment because you don't observe everything. We all have different abilities, different experiences, etc. So that can only grow over time. But hopefully that will answer the question. And if anybody's not satisfied, please ask again.
Lovely, thank you. I've got one for the guys from DLF. Do DLF run a course around the areas within the home? So this was following on from Adam's presentation around kitchen and bathroom environments. Do the DLF run a course around these areas within the home?
Yeah, I'll take that one, James. Yes, we have a home adaptations for professionals course for occupational therapists. It's basically, it's still got 5 modules to it, and 2 of those modules are bathroom design and also kitchen design. And in actual fact, I think there's a course running for bathroom design in London at Fortuna Mobility, and that's on the 19th of November. So yes, it's a very popular course, home adaptations for professionals, and there's, like I said, 5 modules, access to home, kitchen design, bathroom design, multiple levels, and understanding plans and grants. So it is a popular course that professional OTs look to actually completing.
Thank you, David. And if anybody does want any more information about any courses or anything that DLF run, then feel free to give us an email on professionals@dlf.org.uk or inquiries at dlf.org.uk. Thank you, David. Nick mentioned digital resources around provision and self-assessment. What resources are available to assist with self-assessments? I don't know whether that wants to go to DLF or to Nick.
I can take it, James. We have got, and I know a lot of other local authorities have developed them as well. We call it the Citizen Portal. So it is a self-assessment tool. Now, and it's available via our forward-facing Staffordshire County Council's website. But we've built in, and people might have heard about strengths-based approach to supporting people. It is built, we've designed it so it enhances that strengths-based approach. So when people go onto our web pages and start looking at social care, it isn't the first thing that hits them. It's way back in the system, down, well, not the system, it's way back down under layers of other things that people might find useful. Because in essence, what it is a self-assessment under the Care Act. So it's looking at people's needs in the Care Act domains, so that it can indicate whether they've got eligible needs or not.
Fantastic, thank you very much. Damien, coming to you again. Damien's talk points to greater collaboration within a locality between private and public. Do you think, Damien, that this improved during the pandemic, or is there still a long way to go?
I think we've only got the top of the iceberg, really. That's a very complex question, so please don't anybody take this the wrong way. But if I thought this was the first step where I could get together, just listening to the other presentations, I want to set a centre of excellence up where people can come in and feel things years before they need to. So we put it in people's minds. It's like when you pass away, right? You're not the day before looking around undertakers and think I'll go and shop in there, right? It's always a crisis purchase, and we need to get into the psyche of people now through digital, through visual, through whatever it may be, to say to people, look, think about this for your loved ones for the future. Think about, and Adam, I love some of that design stuff. That's like, well, when we tried to help a lady and she went from a bath to the shower, and the shower lip was about 1 inch, and then she couldn't lift her legs because frailty had got to her and arthritis, so she should have had a wet room. So I would say to anybody who's converting their home now, convert a wet room straight away, and then you don't have that in 40 years' time when you're older, etc. So we need to get all those modern technologies and ideas put forward now. And I would, if there's anybody there from Surrey out there, if there's anybody from Elmbridge or any bordering, I'd love to sit down with you and work with the Disabled Living Foundation and the rest of you to come together to actually start saying, we need to think about this now. Because the aging population, there's no staff, it's just going to get more and more chronic in terms of how we deliver, and then that devalues the service because everybody's living on edge, and the amount of mental health issues we've got within our staff at the moment who just work to the bone, it's just chronic. And so we need to think about the workforce and making it easier, and like you're saying, Adam, whether person's left or right, and it makes all the difference for them when they're trying to care for somebody. But we all need to be coming together, and whatever good practice we've got today, we need to move it on, and that means integration between public and private, between small businesses and larger institutions, etc. And look at people as people and human beings and local residents, and not have ownership of them, but how do we best jointly provide the service? So again, I don't know if that answers the question, but I think we've an awful long way to go.
Thank you. Adam, there's a few questions. Oh, sorry, carry on.
Just to add in there in terms of what we do at DLF, I think what Damien says is perfectly right, and what all the presentations have really highlighted is about how we need to think differently about how we design services moving forward, because of the, not just because of the pandemic, which has highlighted lots of things, but just in terms of moving forward, there's agendas around lifetime homes and how they should be designed and things like that. But I think in the meantime, in part of the things we do in Trusted Assessor is trying to make people think differently. So don't just do the course as though I'll take it off the shelf and I'll just do it. It's about adapting it to the needs of your population and your service design and what you're going to do moving forward to ensure that you are providing your service users with a real holistic service provision, not just the usual suspects, but how can we actually look at some of the amazing assistive technology that's out there and how we can incorporate that for our service users, which is something that's really highlighted in what we're trying to push out there at DLF.